Hello, I'm Dr. John Cruz, and today I'm going to be talking about our rates of ADHD really rising. So as usual, I'll start with the take-home message. That'll be done in a minute or two. Then I will give the body of the talk, which will only be 20-25 minutes. Then I'm going to be open for questions and answers, so this video may well be longer than the 20-25-minute talk. Again, if it's much longer, it means there are lots of questions. Questions don't necessarily have to be on the topic for today's discussion. So the take-home message, so my take-home message is that there have been, in the last year or two, several well-done methodologically sound studies that have been performed showing that the rates of ADHD and rates of stimulant prescribing, either in children, adolescents, adults, have all increased over the last 5 years. The most recent study that got a lot of attention was showing in children, so anyone under the age of 18, in 2016, 9.9% had ever received a diagnosis of ADHD in their lifetime. That had gone up almost a point and a half to 11.4%. So that's a measurable increase. So part of my question is why? So every one of these studies, after they've come out, they've gotten lots of pushback and questions showing, oh, this shows we're overdiagnosing ADHD. This shows that people are stretching the diagnoses and don't really fit it. It's not real. And yet, at the same time, and I could not find this just before I went to talk, a recent PTSD study found a rate, and I think it was in children, going from about 4% to about 8% meeting full criteria for PTSD. And the response to that was, oh my gosh, this shows how bad COVID was and how bad our environment has changed and how much has changed. So I believe that our environment is changing in ways that are increasing ADHD, and I don't think we should be the least bit surprised or shocked at increasing numbers. So that's the take-home message. So one of the theories that's been offered each time any of these studies showing increased rates of ADHD come out is that is this simply a question of greater awareness? And when I started working with adults with ADHD in the mid-1990s, virtually nobody in the mental health world, certainly in the general population, understood or believed that ADHD could exist in adults. We've certainly done a lot to increase awareness and education in the last 30 years. But even by the 90s, most people were quite aware that ADHD could exist in children. Yes, there are people who don't believe in the diagnosis or who don't believe in mental health conditions exist at all. We won't get into that right now. But this is a condition that's been around for decades. It's been well publicized. There have been lots of exposés, controversial articles, books about, again, how we're supposedly overdiagnosing. So to me, it wasn't very plausible that greater awareness itself could explain all this increase or changes in diagnosis. That the last time ADHD diagnosis was officially changed was 2013. And if that was what was occurring to cause the boost, you would think that there'd be a steady rate or a step function increase sometime after that 2013 change. That's not what we're seeing here. So one of the things I did for this talk was I went on Google Trends and I just put in the words anxiety, depression, ADHD, and looked at how often people were referring to those terms, using those terms. Depression's had a pretty steady rate, substantially higher initially than ADHD, several times higher. Fluctuates a fair amount, and there's clearly a annual cycle with lower inquiry or lower interest in the summer. ADHD and anxiety also show that. Anxiety starts out at a low level, and then starting about in 2010 shows a pretty steady, substantial increase and is about as frequently a word looked up or cited in Google Trends as depression within a few years. And the ADHD was bumping along at a very low rate. And then in June of 2020 to about March of 2023, more than doubled its frequency of search. and is in the same ballpark range now as anxiety or depression. Now, so that actually looked like people were talking or thinking or asking their computers questions about ADHD more in the last 4 years. But again, some of these increases predate this. So I think this is awareness. I think the Google Trends are showing that the rate were going up and people started asking more about it rather than people got more aware of it, and that's driving the trend. But maybe there is some element or aspect or percentage of the increases which do come from greater awareness. So a few other points I'm going to delve into before I go to one of the studies in a little more detail and then how to assess it is that one of the good things in the studies I'll be talking about and most of what's being done is that they are comparing what I'd say apples to apples or oranges to oranges rather than making apples to oranges comparisons. So some of the studies, particularly when critics claim, oh, the rates of ADHD are much higher in the US than in France, or they're higher in Europe than they are in Asia, or they're higher in this part of the US than somewhere else in the US. Most of the time when they're comparing studies like that, they are looking at different populations. So sampling those populations differently. They're using different methods of assessment to determine who has ADHD, whether it's an in-depth interview, whether it's just a diagnosis on an electronic health record, whether it's just the parent or the teacher. And then the source of information also is varied across studies. So when you're comparing studies that are done differently, I'd say most of the comparisons are pretty much worthless unless you're using the same population, same assessments, same sources of information. And part of that focuses on the rate of a certain condition is not a fixed thing. It's not an absolute thing. It's always an approximation. And it's always in the context of, okay, how did you study it? What was the population you're studying? I even some of the editors on some of the writing I've been doing have focused, oh, you should, put that out to 2 decimal points if that, that the rate of anxiety is 26.4%. And I always push back that we fetishize numbers because we can study them in a particular study. But again, we're using in any study a certain sample, and there's an error rate based on how representative or not that sample is to the general population. Again, so enough said. The studies I'll be talking about are comparing apples to apples. Point two is that some of this falls into the nature or nurture debate. So we know multiple studies have shown that the heritability of ADHD is about 80%. That doesn't mean it's 80% caused by genetics. It means that the amount of variance, 80% of that's shown in severity, symptomatology of the condition can be explained by genetics, which is a pretty high percentage. It's higher than is for depression, but not hugely higher. Depression usually falls in about the 60% heritability. So part of it is that the claim is, and many of the ADHD field have been strongly behind this, including patients and researchers, that this is a real condition because we can show how strongly genetic it is. And if it's genetic, then it should be impervious to environmental conditions or any other factors. So as a counterexample of that, I'm going to bring up, and it's interesting what diseases or conditions or things are lumped as neurological and which are psychiatric. But Huntington's disease, so we'll call it a neurologic condition, it's shows up usually in someone's 40s, 50s, 60s, sometimes earlier. We know the very specific single gene that has been mutated or disturbed or disrupted in this condition. It's an autosomal dominant condition, which is considered to have 100% penetrance, which means if you have this gene, you are going to get the condition. So there, you'd think that's a perfect example of some conditions really are 100% genetics or nature, and nurture has nothing to do with it. So let's say little Johnny as his mother had Huntington's, procreated before she was aware of that. They do the genetic testing. Little Johnny has the gene for it. Johnny's playing on his bicycle in the street one day and gets hit by a car and run over. At the age of 8. Johnny never develops Huntington's. So again, even the most genetically determined condition, there's at least some interplay with what is going on in people's lives, with the environment, with nurture as well as nature. So all of our mental health conditions are both. It should not surprise us that if we change the environment in ways that are ADHD-ogenic or make us all distracted, then we should see rates going up. So the other part of the resistance, I think, is that with ADHD has faced more stigma than many other diagnoses, and stigma specifically, not that it's the worst thing you could have, but stigma in the range of this isn't a real condition. And the claim is it's not a real condition because all the symptoms are things that normal people do some of the time. And it doesn't have any specific, what we call pathognomonic symptom, which is completely diagnostic for the condition. So if you're hallucinating, that's pretty good detail or indicator that you have schizophrenia. That's not something full-blown florid, crazy sounding hallucinations. They can appear in other conditions, but that would be a sign for schizophrenia. Whereas all the things we list as symptoms for ADHD are things, again, some people do some of the time. On the other hand, I would argue that ADHD is our most objective mental health diagnosis, given that it is, the definition as written, is defined in terms of observable behaviors. You don't have to know what someone's thinking. You don't have to know what their motivation is. You don't have to know what they're feeling. You can see if compared to peers in their same age group and cultural background, are they blurting out comments more? Are they interrupting other people? Are they moving around in ways that is not expected of them, and when they're expected to sit still? Are they having trouble being quiet? Are they having... So that, I think, is part of the pushback against why we would not want... So I think both clinicians and some patients are saying, we have a real biological condition. This is real, this is serious, pay attention to us. And if we acknowledge that rates could be going up and the environment could be having a factor, I think the unconscious often feeling is, well, that takes away the seriousness or the biologicalness or the validity of an ADHD diagnosis. It doesn't, but I can see why people might think that. So the study and it's actually coming out this month, it's had a pre-advanced press release, and the article's available online right now. Multiple researchers at the CDC and other governmental agencies and statisticians, and it looked in ADHD in children and adolescents. It used a Census Bureau study. Census Bureau collected the data, trained researchers, trained questionnaires, and they were actually questioning the parents about whether their kid had ever received an ADHD diagnosis. Did they have a current ADHD diagnosis, and did they have other conditions, or what was the treatment? And the study found that, and this is a high number, 1 out of 9 kids under age 18, 11.4%, had received an ADHD diagnosis. That was 7.1 million children. And at the current moment, 10.5%, so that was, I think, about 92% of the children had currently an ADHD diagnosis. So that means about 8% of the kids had received a diagnosis at one time, and that was either corrected because it wasn't accurate, or they had outgrown the ADHD. So that same methodology was used in 2016, and in 2016, the rate was 9.9% instead of, again, 11.4% in 2022, had received a diagnosis, and 8.9 versus 10.5 had a current diagnosis of ADHD. So again, that was statistically significant. It's a measurable increase given that, and again, we're comparing apples to apples here. Some of the other results from this study was that about 78% of kids with ADHD had a co-occurring disorder. And of that total, of those kids diagnosed with ADHD, 54% had received ADHD medication and 44% received behavioral treatment. A lot of these kids received both because almost 30% had not received any ADHD specific treatment. So, which I would again argue is we are grossly undertreating ADHD rather than the claims that we are wildly overtreating it. And the other thing, and I won't get into the finer details, is that traditionally there's been a substantial gender gap in ADHD diagnoses, with boys being much more frequently. So 30 years ago, it was about a 4-to-1 ratio. That's come down to less than a 2-to-1 ratio. And between 2016 and 2022, the gap had narrowed even further. Again, more boys are still being diagnosed, but it's a narrower gap. And the racial gap had also decreased. So even though there's a urban myth out there, in one of my earlier talks, I did talk about race and ADHD. So one of these urban myths is that ADHD is a widely used tool for social control to control little Black boys and give them a diagnosis, and so they can be drugged and not be problematic. In almost every study that's been done, Black kids have received lower rates of ADHD diagnoses, but not higher rates than white peers. We can go into that reasons why. And so again, there is somewhat of a narrowing of the racial disparities in ADHD diagnoses. So another study that got a fair amount of attention about 6 months ago, and also Melissa Danielson of the CDC was the lead author on that study, looked at just filing of, it used a completely different methodology. It looked at an insurer's database, a very large insurer, and looked at what percent of the US population was filling stimulant prescriptions in 2016, comparing that to 2021. And the rate went from 3.6% of the total US population to 4.1% in 2021. That's a half a point increase, not a huge increase, but a measurable one, and occurring over just a span of 5 years, a significant one. But again, and I wasn't able to find this study just before my talk, a study that came out just in last month looked at rates of PTSD in adolescents, and I am making up these numbers, but they're as close as I can remember. The pre-COVID baseline was something about 4% of US children, adolescents met full criteria for ADHD, and it went up to 8% in just a 4 or 5 year period. And again, the response wasn't, oh, you must be misdiagnosing PTSD, or, oh, it's just because doctors are aware of PTSD now. It was, again, oh, COVID and other things in our environment did a number on us, and it's not surprising that PTSD has gone up. So again, there's this marked disparity in how we look at ADHD and how we look at PTSD. So I think there's 6 different groups of people that are muddying the waters here in terms of who gets an ADHD diagnosis. So one is a group of people who would have been traditionally diagnosed, meet the full criteria, have had symptoms since childhood, and we've been diagnosing at least 4 or 5 or 6% of kids for decades. Again, it's gone up steadily, so now 10%. But so we have that population, which clearly meets full criteria. Then we have population number 2. So these are the people we know ADHD occurs on a spectrum. That's well established. There are subsyndromal cases of ADHD, people who have either not enough of the criteria or who show several of the criteria but don't show them quite to the frequency or quite to the level of impairment, or have a lot of frequency of symptoms, but because of intelligence, because of support at home or other aids or accommodations or factors, don't meet full criteria for ADHD, but we know that this is a potentially readily recruitable supply of people to be pushed over into full-blown ADHD. So I think that some of the people during COVID, that the higher rates we saw, were directly attributable to an environment providing less support, less structure, less help, and increased demands pushed some of those people into full-blown ADHD. The third category is what I'd call, and what others have called, secondary ADHD. So those are individuals who showed no previous symptoms of ADHD, and then suddenly, sometime in young adult or middle adulthood, began displaying ADHD symptoms that seemed to be full-blown and permanently there. And probably the most common source of that is traumatic brain injury. So there are a number of documented cases. Many clinics, brain trauma clinics, routinely see people who had no previous history of ADHD, and then a brain trauma replicates a full-blown ADHD picture. That's separate from the fact that ADHD is a risk factor for developing traumatic brain injuries. And I do have another talk on that in this YouTube channel. Other potential causes for secondary ADHD would be drug use. That's often thrown out there. I don't know of too many documented cases where extensive, usually street stimulants or other drugs, caused permanent changes which look like ADHD. I would posit dementia is another one of these. So there was a study that came out of Israel a year or two ago. It got lots of attention for the claim that ADHD was a substantial risk factor for dementia, but all the cases, or what they looked at, were people who by middle age had not had any ADHD symptoms, then started developing ADHD symptoms, and then those people who developed ADHD symptoms had a higher rate of going on to full-blown dementia. I think it was a complete reverse causation. I think what they were looking at were early manifestations of dementia can often look like ADHD. So that would be secondary ADHD. I haven't heard other people use the term, so I've just thrown it out as tertiary ADHD, and that's what I call people who have no previous ADHD but develop a full display of ADHD symptoms, but it's temporary. So we know sleep apnea can do that. So there have been cases of kids and adults with sleep apnea looked exactly like they had ADHD, not just attention, not just concentration, but emotional volatility, impulsivity, hyperactivity, the whole picture. And you treat the sleep apnea, and in some of these cases, the ADHD goes away completely. That would be a reversible cause of ADHD. Officially, it's not ADHD because it has a different cause. Whether modern technology, immersion in cell phone culture, and or something like post-COVID, clearly both of those are able to replicate an ADHD picture, a fairly broad-based ADHD picture. How reversible those are, or how frequently these are occurring, we don't know. So the other two categories of individuals are those individuals who really don't have ADHD, but who have symptoms of depression or symptoms of anxiety or symptoms of PTSD that mimic or overlap with ADHD. And many of the critics of this rise of ADHD say that's all we're seeing, that these are only people with depression, only people with anxiety, only PTSD. They don't really have ADHD at all. But with some moderately careful questioning, there are clearly many people with new onset ADHD who don't actually particularly have any depressive symptoms, or who aren't anxious, or who don't meet PTSD criteria. Right now, we're simply at the stage of arguing anecdotes versus anecdotes. Nobody that I know of has done a recent survey or study trying to individually assess whether new ADHD cases, what percent of them could be really attributable to another mental health condition. And then the sixth category, and again, some of the pundits, some of the media make it sound like this is the biggest cause or explanation, is individuals who are asymptomatic, they really don't have any ADHD symptoms, but they're just wanting either accommodations that are associated with an ADHD diagnosis, or they're seeking stimulant drugs, a reliable source from them rather than buying on the street. So these are people who have faked their ADHD, and there are dozens and dozens of research articles about faking ADHD and malingering and pretending and how to detect it. So people think this is a huge problem. I think the data is pretty clear that the substantial majority of individuals who are seeking an ADHD diagnosis, including seeking medications, are doing it because they do have substantial ADHD symptoms. And again, the number one reason those individuals who are labeled as misusing stimulants, prescription stimulants, is to help with focus, help with stay on track, help address ADHD symptoms. It's not to get high. I'm not pretending that there are no people like that, but that's so. From what I see, I think ADHD has long been plagued by underdiagnosis. So I didn't emphasize that point enough. That particularly missing it in racial minorities, missing it in women, is pretty clearly a case of underdiagnoses. I still see in adults many more examples of underdiagnosis than overdiagnosis. So I think we are living in a world that in many ways is pushing many brains to be more ADHD-like, and some of those will have real, genuine full-blown ADHD. Some may be a ADHD-like condition. Some may be a transient ADHD condition. So that's about all I'm going to say for today on that topic. Next week's topic is what drugs make ADHD worse? That was suggested by one of my listeners. Thank you. And I do see some questions, so I'm going to be jumping to those now. So Omagro says, could the constant stream and fluctuation in dopamine from social media could be at fault? Seeing as how most things are engineered to trigger the reward center, I feel that has a role. So I've talked about it here. There's lots of people writing about it at this time. I think social media is a major factor, and I'm not even sure it's purely the reward aspect, but it is a constant intrusion. It's always there. It's always interrupting. It's always pulling attention away. It's been engineered to do that by people who studied psychology, and it's very effective at doing that. And the more people that are and part of its power is shown by how it's having power when its device isn't even on or in front of you, the extent to which people have withdrawal, the extent to which students, when they have to turn in their cell phone or turn it in during a class, are still thinking about it during that class time. So yes, this has hijacked our brains and attention. But again, and most of the research is focused on attention, but I think there is some evidence to support that we are actually seeing a broader range of ADHD symptoms in terms of poor time management, in terms of emotional dysregulation. So these devices, we focus so much on the attention, aren't just disrupting attention, they are creating a broader ADHD picture. So hello, Dennis. Dennis asks, why was digoxin Gradumet discontinued? I'm sorry if it's covered in another video. I know that there are still forms of digoxin available in the US. So digoxin is methamphetamine, a different drug than dextro or levoamphetamine, which is amphetamine's active ingredient in Adderall and dexedrine and Vyvanse, several other preparations. Methamphetamine has an extra methyl group added on. It leads to faster, more rapid dopamine release. It is clearly more addictive. It's clearly more prone to causing psychosis. I do have a whole video on that. So Digoxin is still available in the US, at least the last time I checked. Different countries have their own rules and regulations, and a lot of this is equal amount science and politics, as we're seeing with attempts finally now in the US to downregulate marijuana use, which has been linked as dangerous as heroin and other substances which have no clear medical use. So sorry, I don't have the specifics. And as someone pointed out in the question and answer, there are some cold relief products which have tiny amounts of methamphetamine in them that you can buy over the counter at Walgreens and other chain drugstores. It's tiny amounts, but and presumably is part of a decongestant effect. Hello again, Mr. AKA 1996. Maybe part of the reason is decreasing levels of testosterone. Have you ever had a hypogonadal patient resolve their ADHD symptoms after starting it? So I do have a talk on testosterone. The only specific individual I have who noticed a marked improvement in ADHD symptoms was actually a woman who was taking testosterones for some menopausal, presumably related hormonal changes. She hadn't tolerated estrogen or progesterone. There are a few case reports of individuals given testosterone, some for hypogonadism, sometimes where it did markedly improve ADHD symptoms. I've talked with several patients I have who've had prostate cancer, and then part of the prostate cancer treatment is often Lupron, which suppresses testosterone dramatically. And some of them, once they've gotten off, so none of them have had a onset of, they've experienced fatigue, they've experienced less energy, less sex drive, less zest for life in general, but none of them has that Lupron elicited a full ADHD picture, and none of them, when they stopped Lupron, or some of them have even gone on to a low dose testosterone subsequently, none of them experienced that sudden, a dramatic change in what would be ADHD-like symptoms. So that's what I would say there. So Mr. AKA 1996 asks, have I ever had a patient develop serious QT prolongation from a psychiatric drug I prescribed? What happened? And the answer would be no, I haven't. Part of it is that, not that this isn't a real phenomenon, not that this isn't possible. So QT is part of the EKG. The different parts of the cardiac wave are given numbers or letters, and the QT interval is part of the heartbeat that can be extended by certain drugs. And if it extends too long, it can actually wind up causing a fatal arrhythmia. So drugs can cause this, but most of the evidence is that most of these, you either have to have really pre-existing weird genetic heart abnormalities to begin with, or you have to be, most of the cases have been substantial overdoses, either intentional or otherwise, that ran people into trouble. Not all of them. Some of them have happened for other reasons, but there's, people saying, trazodone is a drug that has mild QT prolongation. Oh, you can't use it with an SSRI. Well, we know the vast majority, more than 90% of trazodone use has been using it for sleep, for people who are on other agents, many of which also have some mild QT prolongation. And the number of studies of individuals who have gotten into serious trouble with this is vanishingly tiny. Again, horrible if you're one of them. I'm not saying blithely prescribe big doses of medications, but many of these risks, I would say, are overhyped. So Ali asks, what should I do if the medicine does not work? I used Ritalin 10 milligrams and did not show any results. Hopefully you have a good practitioner you're working with, and your job is to report back what you experience in terms of good effects, in terms of side effects, or in terms of I'm not seeing anything. Part of what's tricky with ADHD is that, and this always sounds a little pejorative, but it's a measurably true statement, is that ADHD, because it impairs attention concentration, does impair someone's own ability to assess what's going on with them. So that's why we often try to get quasi-objective symptom ratings or objective measurements, like how many minutes can you sit and read a book without getting distracted before putting it down. If that's increased, you might not have noticed that if you didn't try to do a book. Or how quickly can you get through your emails in the morning? How quickly can you do it in 10 minutes rather than an hour? Because usually you would get sucked into down some rabbit hole. And using collateral sources. So if you have a partner, if you have even friends or workmates who are willing to give you feedback that, yes, I've seen this or this change since you started the medication. So if there's really no change at 10 milligrams, the usual approach, and it's not just mine, it's most people who work with individuals with ADHD, would say, don't spend more than 2 or 3 days getting no effect. The next step should be to go up. Now, if you're already having side effects, then that would show, and they're intolerable, that says, okay, you've given a good shot. This medicine is intolerable for you. So I do have a whole nother talk on dosing, that this is a condensed version of it. But I tell people, do not focus on the numbers. We are not trying to treat the numbers. We're trying to treat you as a person. And you as a person means we're trying to reduce your symptoms. We're trying to avoid any side effects. If we're doing that, great. And we shouldn't care whether that's 5 milligrams of Ritalin or 180. And I did have patients on doses that were that high. Not a lot of them, but a few. We know that there are huge variations in terms of how people's bodies handle these drugs. So Brian M. asks, my question isn't directly related to your topic this evening, but it's on my mind. What explains the varying degree severity to which those with ADHD may experience time blindness? Yeah, so I don't know a single ADHD trait where we know precisely why some individuals are more hyperactive than others, why some individuals are more prone to blurting things out, why some people. So I don't know that, I don't think for any of our ADHD symptoms we've identified why time blindness is more a problem for some individuals than others. The interesting thing with the time blindness is that the data suggests it's not just a chronic underestimation or overestimation. It's errors get made in both directions. So I think I've even talked on time blindness. I'm not sure which topic it is. It might just be time perception. So sorry, I don't have a good answer for that. So Blake Gransdell says, my wife was just diagnosed at 37 years old after her screening. She was diagnosed with the comorbidity of bipolar. Is bipolar a common comorbidity of ADHD, particularly in women? Thank you. So yes, and I'd sort of throw in an important no. So yes, statistically speaking, people with bipolar disorder are more likely than the general population to have ADHD. And people who have ADHD are more likely to have bipolar disorder as well. I've seen huge numbers of people over 30 plus years who were diagnosed with bipolar disorder, many of whom who pushed back and said the diagnosis didn't seem to be fit, and or whose therapist said that, and a prescribing physician still insisted that was what was going on. And many of these individuals turned out to have ADHD and not any bipolar disorder. So yes, they can occur together. Yes, they are more likely to occur together than by random chance. But yes, this is an area where there is considerable overdiagnosis, misdiagnosis, not missed. It's not that they missed the diagnosis, they made the diagnosis when it wasn't appropriate. So I have a higher threshold for identifying bipolar disorder maybe than some of my colleagues, but I have some colleagues who literally anyone who walked in the door came out with a bipolar or somewhere on the bipolar spectrum. Um, I think it's a useful concept that there's a spectrum of bipolarity. There are some individuals who only have depression and are only going to, but many individuals have some combination of mania, hypomania, and depression. But I think far more so than I've seen with ADHD, that bipolarity is a overdiagnosed condition. So I would make sure that the individual has had discrete episodes of depression and or mania and or hypomania. And I particularly, and I've talked about this and I've written about it on Medium, talked about mood swings. I think it's a horribly misleading term because some people think it just means, oh, I had a one mood now, one emotional reaction now, or no reaction now, and 2 minutes later, something triggered me to be angry, and then 3 minutes later, someone triggered me to be sad or joyous or something like that. That's mood reactivity or volatility. For mania or hypomania, you have to have a sustained period, and hypomania itself is at least several days, mania, it's weeks, of prevailing mood in one direction. And within that, there is a lot of volatility of mood, but just a change in mood is not a mood swing or evidence of bipolar disorder. So I'm not seeing any other questions. The time I'll be shifting 4 hours earlier next week, and that will be the new time on an ongoing basis. So thanks for the questions today. Thanks for being attentive. Stay healthy, stay happy, and see you next week. Good night, Dennis.